Hello and welcome to the webinar. My name is Julie and I will be acting as moderator for today's webinar entitled Infection Control Policies and Practices for Medical Respite Program, a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Office of Special Population Health. This is a 1-hour presentation with the last 10 minutes reserved for Q&A. I now turn the mic to your event host, Sabrina Edgington. Sabrina?
Thank you, Julie. My name is Sabrina Edgington. I'm the Program and Policy Specialist here at the National Healthcare for the Homeless Council. I also staff the Respite Care Providers Network. So I'm your contact for all things medical respite related. Feel free to contact us with any of your technical assistance and training needs related to medical respite care. I'm very excited to introduce our two presenters today. Our first presenter is Jessie Gaeta. Jessie is the Co-Medical Director of Boston Healthcare for the Homeless Program, supervising medical practice of Boston Healthcare for the Homeless Program's physicians, nurse practitioners, and physician assistants. She most recently served as the Medical Director for Boston's Barbara McGinnis House Medical Respite Program from 2009 to 2011 and has been with the organization since 2002. Our second presenter is Timothy Johnson. He has been working with homeless individuals in an administrative capacity for nearly a decade. During this time, he helped develop projects and initiatives aimed at preventing the spread of tuberculosis. Tim previously served as the chair of the Respite Care Providers Network, a standing committee of the National Healthcare for the Homeless Network. At this point, I'd like to hand it over to Jessie to begin her presentation.
Thank you, Sabrina. My name is Jessie Gaeta. As Sabrina said, I'm from Boston Healthcare for the Homeless Program, and I'm going to be talking today for about the next 20-25 minutes on infection control policies and practices for medical respite. And just want to start by saying that I think infection control for us in respite is sometimes daunting, but I want to encourage everyone that this is something that can be accomplished no matter what our no matter what our facilities are like. To some degree, in any type of setting, we can make an effort to prevent transmission of infections. I also want to mention, before I launch into my slides, that I've submitted to the Council a sample packet of infection control policies for respite facilities that would love to offer to you just as a sample or a reference or a starting place to think about building or strengthening your own infection control policies. And those will be made available with the webinar recording. So I just thought I would start with some general principles of infection control, which aren't going to sound too exciting, but are really the mainstay of infection control. And the first is that standard precautions should really be in place always. I think in any kind of medical facility, this is something we want to continuously encourage our staff to do. And standard precautions, which is formally referred to as universal precautions, are really meant to be used during every interaction with patients, regardless of their diagnoses or their presumed infection status. And I'll talk a little bit more about standard precautions, just to reiterate some things I'm sure everyone here knows already. And then I thought I would move to talk about precautions that are based on the mode of transmission, or transmission-based precautions that we use when indicated. And these are precautions that are really designed for patients who are suspected of being infected with highly transmissible or epidemiologically important pathogens, for which we put in place some additional precautions, ideally, beyond the use of standard precautions. And there are actually 3 different types of transmission-based precautions that I'll review briefly today. And those are airborne precautions, droplet precautions, and contact precautions. Wanted to also just make the point that we've found it really helpful in our respite facility to have a point person to make decisions about individual cases that inevitably come up fairly frequently. And in our facility, we've used clinical administrators for that as that point person, including a director of nursing or a medical director. And finally, and this is probably one of my key take-home points, is that I feel like as respite programs, we really need to have a can-do attitude instead of a pushback attitude, as much as we can and still feel safe, and so that we're going to really sort of do the best with what we can. While I'm going to be presenting to you some infection control policies that may seem pretty intense and may seem sort of closely aligned with an infection control policy in a hospital, I hope I also can interject examples of ways to do things differently depending on your own circumstances. So moving on to just review standard precautions, really the mainstay of infection control that we can never stress enough with our staff and should always be in place. And I just thought I'd say a couple quick things about hand washing in medical respite facilities. This can be done really with plain old soap and water, which is fantastic. It can also be done with a waterless antiseptic. Those are both acceptable. And the times we really want to be reminding people to use to be hand washing again are before and after each patient contact, before and after using the bathroom, certainly before and after eating. And I think for staff, in addition, we really want to stress the piece about washing hands between patient contacts. To make that accessible for folks, it's one thing you see done a lot in hospitals, and I think respite facilities are increasingly doing, is to have hand sanitizer available in all the rooms that we have encounters with patients. Gloves are also a part of standard precautions in certain circumstances, and those are when contact is expected between a staff member and a patient, contact with blood, body fluids, secretions or excretions, excluding sweat, or when skin is not intact, or when coming into contact with mucous membranes. And so those are times when we really should be encouraging our staff to be wearing gloves. Would also just mention one other caveat about gloves, which is I think it's a good practice to encourage facilities or maintenance staff to be using gloves when they're handling linens or specimens or even medical waste of any kind. There's other protective equipment included in standard precautions in certain circumstances, and those include things like gowns and eyewear. We have just a very limited amount of those things in our respite facility due to the cost of those equipments. I'm going to move on to talk about transmission-based precautions. I mentioned there are 3 different types based on the type of pathogens and how they are transmitted, and I'd like to review those briefly. The first one, which I'm not going to talk in great detail about because our next presenter will do that, is airborne precautions. And this set of precautions is really meant for pathogens that can be transmitted by very small droplet nuclei or dust particles. They are described as being smaller than 5 micrometers, so very tiny nuclei that can travel significant distances through the air. And for these pathogens, the best type of infection control is accomplished with special air handling and ventilation specifications, which which we're able to do it to a very limited extent in our respite facility, and I know that others have experience as well. And this is actually a topic that Tim will be covering in a few minutes. So the pathogens that we most often encounter that fall into this category are 4, and those are pulmonary tuberculosis, disseminated varicella zoster infection, or disseminated herpes zoster, varicella pneumonia, which we see very rarely in patients with, typically with who are immunocompromised. And I also mentioned measles as the 4th, only because we had an outbreak of measles this past year in Boston, and we encountered that for the first time. So there are 4 pathogens I thought to mention in this category that really require very special air handling and ventilation that many respite programs may not be equipped to handle. The second category is droplet precautions, and these are precautions we take for pathogens that are described as being large particle droplet pathogens. And these are larger than 5 micrometers, and that means that they can't travel as far in the air. In fact, they typically would travel only within 3 feet. And so there's really a very different type of precaution that is needed for these types of pathogens. And these precautions are meant for droplets that are formed during coughing and talking, suctioning if that's something that's done in your facility. And special air handling, however, is not required since these pathogens don't travel very far through the air. So common examples of pathogens that need droplet precautions are influenza, pertussis, MRSA or MRSA pneumonia, and less common ones are mumps and rubella. In fact, there's a much longer list of infections that you'd see very rarely included in some of the materials in the packet provided to the council for your reference. So droplet precautions in our facility are accomplished when we're able with a private room for a patient. And I have to say we're probably able to do that pretty infrequently. More commonly, we try to cohort patients who have the same infection, and this is the case every winter with influenza or influenza-like illness, where we suspect a group of people to have the same pathogen. So we cohort people in the same room, and we ask that when the patients leave that room that they wear masks, and these are not the N95 respirator masks that are really necessary when dealing with an airborne pathogen. Instead, they are basic surgical masks. In addition to that, we ask staff members who come into come into contact with patients to wear the surgical masks as well when we're dealing with pathogens for which we use droplet precautions. The final category of precautions are contact precautions, and these are typically used for various types of skin pathogens and pathogens that cause gastrointestinal infections. These are pathogens that are most often transmitted really through direct or maybe through indirect physical contact, but there is no travel of these pathogens through droplets in the air. So there has to be skin-to-skin contact or the physical transfer of an organism through some kind of intermediate object or a fomite, like a stethoscope or linens, etc. And in terms of the types of precautions we use with these infections at the Barbara McGinnis House, we also try to provide patients with a private room. I have to say that's it's again pretty unusual for us to be able to do that. And when we can't do that, our next best thing is to cohort patients again. In terms of, and we actually sort of prioritize using a private room in the case of skin infections that have, particularly large wounds, or if there's real, copious drainage. Or the other scenario would be the patient who is really not managing their hygiene very well. Those are folks who, for whom we'll really make an effort to be in a private room. And in terms of the GI infections for which we use contact precautions, and I'll name some examples of those in a minute, that are transmitted via the fecal-oral route, we really try to have patients cohorted in the same room and sharing their own bathroom. So we'll have a bathroom that is used for patients who are symptomatic and not used by patients who are not symptomatic, since the bathroom, in the case of GI illness, is a place of high likelihood of transmission. The one caveat I would say in thinking about private rooms and cohorting for droplet precautions or contact precautions is that you have to be very vigilant in making decisions about the private room or cohorting when you're dealing with patients who are immunocompromised and for whom you may not know what type of infection they have. And so it's pretty risky, obviously, to have an immunocompromised patient share a room with a patient who has an infection if you're not sure that they both have the same infection already. And so that's one time when we're also really making an effort to have private rooms available. So I thought I would just run through a couple examples of both droplet and contact precautions, leaving, again, the discussion about airborne precautions to my colleague in Ohio. So we're going to start with influenza. This is an infection we see dozens of cases of a year here in our medical respite facility. And for this, again, we use droplet precautions. We provide a private room if available. That usually happens just for maybe the first or second patient, but by the time we've got more than 2 or 3 patients, we begin to cohort patients with suspected influenza. And I would just like to maybe point out, if you're in a type of respite facility where private rooms is not possible, or possibly even cohorting is not possible, then it's best to really spread beds as far apart as you can, remembering that these are particles, these pathogens are particles that can travel typically no more than about 3 feet. So it's good to have 5+ feet, I would say, between beds. That will help. In the case of influenza, we ask patients again to use surgical masks when they leave their infectious area, their room, and any staff who are visiting patients in that room would walk in with a mask in place. We make a big effort, and this is probably one of our biggest challenges, to try to minimize the mingling of patients who we think, who have an influenza-like illness with other patients in the general respite population. And we do that by creating different times for infectious patients, for smoke breaks, and for meals. We even go so far as to try to serve meals at the bedside. This is a big struggle, as you can imagine, since it's difficult to be isolated for for a number of days away from many other people. With influenza, I just thought I'd quickly mention about the period of infectivity being quite a bit longer than you might expect after symptoms resolve, which is a frustrating thing for patients. We decide how long we're going to isolate people in either the private or cohorted situation. We look at updates from the CDC, which happen on a periodic basis. At the moment, we are isolating people in respite for 5 days after the resolution of symptoms, based on sort of loosely based on the CDC guidelines of what they would do in a community institution with a lot of people. I'm going to talk next about the example of norovirus, which is timely because we actually have an outbreak of norovirus that is very widespread at the moment in Boston. And we've had about 50 cases of norovirus in the last 4 weeks between our patients in respite and our staff members. So this is has been on my mind a lot lately. Norovirus is, again, transmitted via fecal-oral route, causes a self-limited nausea, vomiting, diarrhea illness, typically 48 hours or so, self-limited for most people. We use contact precautions. We start off with private rooms. We quickly go into cohorted rooms as people, as more and more people develop the symptoms. We make every effort to have people who are infectious using certain bathrooms and everyone else using other bathrooms. We institute gloves when we're coming into contact with patients, when we're dealing with norovirus. We go on a completely aggressive campaign for hand washing among both staff and patients. In fact, we place a staff member at the entrance to the cafeteria. People are not allowed to get in for their meals before they're washing hands with the sanitizer, and on the way out again. We distribute the hand sanitizer fairly widely. We also, in the midst of a norovirus outbreak or with any potential cases of norovirus, ask our facilities and maintenance staff to really bump up the frequency of their cleaning with an emphasis on bathrooms and common surfaces. And One just tip I'll give about that is that while this virus is typically transmitted fecally orally, it has been described that people who come into close contact with vomitus or stool, so in other words, folks who are cleaning, that in theory at least it's been described that particles can be inhaled. So we actually have our facility staff wear masks in the midst of a norovirus outbreak if they're coming into contact with those secretions. And again, we go through a lot of effort to try to minimize mingling. And through all these efforts and more, including town hall meetings, we have been able to very gradually see a trickle off in the number of norovirus cases in the last couple weeks. So we're down to, today is the first day I think we have no new cases. Got two other quick examples. They include Clostridium difficile. I mention this because I think it's a pretty common pathogen that we see in respite. Patients typically are coming from the hospital and have made it through a period of really profound symptoms and have come to us rehydrated and usually already started on antibiotics. The number of their bowel movements per day is usually dropped off quite a bit, and so has their infectivity. The way that we cope with C. diff at the Barbara McGinnis House really is, again, with contact precautions, which I won't go through again, but with a couple caveats. And one is that I've been taught by our infectious disease colleagues in a local hospital that C. diff is not eradicated with most waterless hand sanitizers, and that good old-fashioned soap and water is actually the best way to get rid of C. diff bacteria from the hands. So we actually educate the patients and staff about that every single time we have a patient with C. diff. And this is probably an infection where it's helpful if gowns are available to have staff members wearing gowns as they're taking care of patients, particularly if it's a patient has trouble with sort of personal hygiene. The last example I thought I'd talk about is the very common examples of methicillin-resistant Staph aureus infection. And I'm going to give you the example not of a person who is simply colonized with MRSA, but instead the example of a patient who has a wound known or suspected to be due to MRSA. I confess that we aren't as vigilant at the McGinnis House as we should be around this issue, and I'll tell you that we have now probably about 55% of the Staph aureus isolates from our community are MRSA, so they're feeling so ubiquitous that it's overwhelming to maintain this level of precaution, but we're doing our best. And so what we do with a wound infected or suspected to be infected with MRSA, we institute contact precaution, which again means a private room, particularly if there's copious drainage or a very large wound. We ask staff to wear gloves. We ask them to wear gowns when those are available. And I'll just say one last thing about MRSA is that while we aspire to be documenting our patients who are colonized with MRSA and using contact precautions with them, it's really sort of become pretty overwhelming for us to do that just because of the sheer prevalence of that. And so we're really using the contact precautions in our community based on the prevalence for active infections and not colonization. And then I'll also mention about MRSA that if a patient has a known MRSA pneumonia, we are then implementing droplet precautions because that is spread in a different way than a skin infection with MRSA. Okay, and actually forgot one last one, which if you're like us, you see this very frequently, and there's always questions from staff around this infection, and that is localized herpes zoster. This is an infection that leaves skin lesions and is typically, in the case of localized zoster, confined to just one dermatome, and that is a key piece of the equation for us. If we're dealing with localized zoster in an immunocompetent patient, a healthy patient, we then use standard precautions. We don't even use contact precautions, but standard precautions. In addition to that, we make an attempt, and it's usually pretty easy, to cover the lesions with gauze and then clothing. For patients immunocompromised with localized zoster, that is a case that would be discussed with our point person, in our case our medical director, to decide whether or not there's a chance of this infection being disseminated, and that can be subtle, figuring that out. If disseminated zoster is suspected, that is an infection that is spread through the small particle droplets I described earlier that requires airborne precautions. So that's a patient who, again, would need specialized air handling and ventilation, which we can do if we have a negative pressure isolation room available. Otherwise, would really need to be cared for in an acute hospital. The last thing I'll say about localized zoster is that it's very important for staff to be immune to varicella zoster. Most of us are if we've had chicken pox. The CDC, however, has recently changed, about a year ago, changed its recommendations for healthcare workers that we can no longer assume that we're immune because we have a history of chicken pox as a child, but instead really should be proving our immunity with a titer and then being vaccinated if we are not proven to be immune, or that we should be showing documentation of our vaccines for younger staff members. So this is an important piece because we inevitably have a little bit of panic in respite when we have patients admitted with zoster among staff who may be or are pregnant. And the only thing I'll say about that is to reassure folks, and we do this a lot here, that it comes up with every single admission, to reassure folks that pregnant women who are immune to varicella, there is no increased risk to the fetus from the varicella. So the key piece is that you really want all of your staff immune. And the last slide here, I just thought I'd share a couple other tidbits about infection control and respite, and this sort of piggybacks on my last point, which is it's a really healthy thing, I think, for a respite administration to promote immunity among staff and patients for a number of infections. And we've just in the last 3 months made this a requirement for work in our respite facility. And this has happened in hospitals all across our state, actually, that we must prove immunity to measles, mumps, rubella, varicella, hepatitis B, and influenza and pertussis we've made recommended, but not required. One reason we went to that is because we had a measles outbreak here in Boston this past fall, and we had a patient who was potentially exposed in an emergency room to measles, which is probably one of the most highly infectious agents I've ever dealt with. And our public health department said to us, if you cannot prove immunity today of all of the staff members who have seen that patient, come into any contact with that patient, those staff members must be out of work for the next 20 days or until you can prove their immunity with titers. And so the public health department really gave us a very tall order, which we weren't able to meet, and so had some issues with staffing. And so since then, we've really decided to make that a requirement. The other tidbit I'll say is in the midst of outbreaks or unusual infections that you have in your respite program, we found it really helpful to hold town meetings with patients and answer questions, educate, review standard precautions, and how people can prevent getting infected. And with that, I'll end and pass the conversation on to my colleague in Ohio, Tim.
Hi, my name is Tim Johnson. Thank you, Jesse. I definitely will have a lot of questions possibly in the Q&A session. So again, my name is Tim Johnson, and I am the Chief Executive Officer of Harmony House, Inc., and we operate several programs, mostly respite programs. But I'm going to talk today about the Langston House TB isolation room facility. And I'll be speaking for about 10 to 15 minutes, and then we'll have time for Q&A. So to give you a brief summary of what I'm going to talk about the history of our TB recovery programs in our isolation room facility, barriers to creating this program, some public policy issues about why we had to create a program such as this, a brief overview of our program and how it operates, and some photos so you can get a better picture in your mind about what it looks like in our isolation room facility, and then we'll have Q&A at the end. So the brief history started, I guess, in 1998 when one of our board members worked for the City of Houston TB Control, and he, during his field work, always encountered a problem, and that problem was placing people that needed their 6 to 9 months of TB medication while they were no longer infectious. There was no place to house them, and the TB control workers would travel around the city and try to locate the person that they just medicated the day before, and it was always very difficult to find those individuals the next day when they needed to take their next days of medication. So what we did, working with the city TB control, we wrote a grant with the Housing and Urban Development for transitional housing, and we housed 6 individuals with TB in our facility for the 6 to 9 months, and we provide the DOT therapy and place them in our facility with 3 meals a day and all of the case management, and help place them into housing afterwards. And so that had been working for over close to 10 years, until around 2006 when we started receiving phone calls from the City of Houston to see if we could place people that were still infectious and into motels. And we weren't really equipped to do that, and the city was doing it themselves and ran into lots of problems. And some of the examples that we had where people that were placed into the hotel would have their friends over and have parties while they're infectious. And another case, a guy convinced the cleaning staff at the motels to help bathe him, and there were no medical precautions. So those persons were exposed and became contacts for extra contact investigations, which cost the city money. So what we did was work with the City of Houston and said, hey, we have a facility, a house that we have that has 7 small rooms that we could possibly convert to isolation room facilities. And after purchasing equipment, HEPA filters, the portable kind, we placed them into the rooms and created the negative flow isolation rooms, and we officially started in April of 2008. In our funding, initially we received a foundation grant to kick off the funding, and we received the State of Texas grant from the Infectious Control Department and funding from the City of Houston. Since we've been open, we've served 6,400 bed days of patients in our program, and we saved the hospitals over 5,000 bed days. Basically, what happens is a person goes from the hospital to our facility after being diagnosed with infectious tuberculosis, and they then stay at our facility until they're no longer infectious, and then they transition to another housing option after that. So some of the barriers that we've found, I guess the biggest barrier is money. Since we've been operating, we've always had tenuous funding where we didn't know from day one where the money was going to come from. But everyone thinks that the program is very important because in our community, the hospitals release infectious people onto the streets. So the second, I guess, barrier would be buy-in from the hospital community. Since they don't have any requirements to place individuals into a proper housing situation while they're infectious, or any requirements to keep them in isolation until they're no longer infectious, the hospital community doesn't seem to think that it's important to help support our program, the Langston House. Barriers from participants are varied. The participants do not like staying in isolation for extended periods of time, as probably it would seem like they were in prisons, even though our program kind of operates on the, I guess, honesty policy. You are there while you're infectious at your own free will. There's no court order in our program, and that's one of the differences between our program and what the state of Texas has. They have a program where you receive a court order and they place you into the isolation, and that really is like a prison. And another barrier is the public policy. Public policy in Texas does not require hospitals to keep participants in isolation until they're no longer infectious. And so that would, I guess, create the need for our program where if they were required to keep them in isolation, then our program wouldn't really have a need. And again, the public policy is local government doesn't require a person to remain in isolation while they're infectious, and local government doesn't require a suitable discharge plan for persons with infectious disease. So the overview of our program, we start at the top. You see public agency and hospitals. So we get referrals from hospitals through the City of Houston TB control program, or referrals from a public agency who may suspect that a person in their program may have infectious tuberculosis. And what would happen at that point is if the public agency calls us, we would contact the City of Houston TB control and let them start the investigation. And the benefit of that is this person may have suspect TB infection, and he could be placed in an isolation room in our facility without even going to the hospital. So that really cuts out a lot of cost by being able to place someone into isolation without having to go to the hospital, while labs can be run to determine whether they are actually infectious or not. And most of the time we received participants like that, they were placed correctly, and they did have infectious tuberculosis. So once they're in the Langston House program, we work with the City of Houston, determine what their level of infection is and what their DOT regimen should be. Our staff will then work through their DOT plan, give them the proper medications, and they will stay until they're no longer infectious. And the stays in our program range anywhere from 3 days to 120 days. It depends on whether they can have a negative sputum and no longer require isolation. And at our facility, we use an N95 mask for our staff while they're working inside the building. We have actually the building with the 7 isolation rooms and then an office outside the building where our staff member typically resides until he may be needed to go inside. Then he will place his N95 mask on, go into the building and do what he needs to do, and then leave. If he needs to have a meeting with a client, he may go get the client and bring him outside in sunlight, at daylight, so that it would reduce the chance of infection, even though he's wearing the N95 mask. The participants wear, I guess, a regular mask, and I'm not sure what the term for that, the basic mask is, but it's just not allowing the aerosol to infect our participants. Most of our interactions are outside. We have HEPA filters. They change the air about, I want to say, maybe 12 to 20 times per hour. And I think it was about 3 times more than what was required for negative flow isolation. After they're no longer infectious, they will then go to our TB recovery center where they'll receive the remaining 6 to 9 months of DOT, or they may go home. And here's some photos of what our isolation rooms look like. There's a hospital bed, a cabinet where they can place their clothes, and you can see on the picture on the right the HEPA filter unit. It has intake at the bottom, and the air is filtered through there, through the HEPA filters. And actually, it looks like a vent here, but that doesn't exhaust air back into the room. It has a pipe that you cannot see that exhausts air through the ceiling outside the building. And these rooms have a refrigerator and a television with cable, so that the participant will feel like they're at home and have something to do and be comfortable living in this situation. So with that really ends what I have to say, and I will pass off the mic to Sabrina, and then we can take question and answers.
Thank you, Tim. So I have a couple of questions, and for others who haven't yet submitted your questions, please feel free to use the chat box underneath the screen to submit any questions. But this first question is for Jesse, and the question is, how effective are curtains used as dividers in congregate settings where limited space is available to move beds apart?
Thanks, Sabrina. I think that they are a decent alternative. I'd say if you don't have any other type of dividers, go with the curtains. I guess I would sort of rank them, wall is best, and if that's not available, probably a divider that comes all the way down to the floor if you think of the way particles will travel and then drop, and curtains tend to not come all the way down to the floor, and they also, they're sort of, they're fabric, so they're not ideal. I think that hard foldable dividers that come all the way to the floor are probably better than curtains, and then curtains are better than no divide, and that's sort of how I would rank them.
Thank you, Jesse. And we have a question for Tim. Do you anticipate more hospital interest in your program as health reform provisions around care transition and reduced readmissions are put in place? I
think maybe not in our isolation room facility, because they realize that we're still open after basically 4 years. But in our regular respite programs, I think they will find more interest in placements because of those new rules.
Great, thank you.
This is Jessie again. I see a question popping up. Do you actually order lab tests to confirm norovirus? And the answer is that we took instruction from our local public health department, and as we were seeing upwards of 20 plus and then 30 plus cases, they finally said, yes, I think we probably should go ahead and confirm it. So they actually came in, they sort of swept in and collected 3 samples, stool samples from 3 separate patients for us, sent those samples off, and we had an answer in about 48 hours that all 3 were confirmed norovirus. But we don't do that typically. In this case we did, so I guess we sort of hit a certain threshold that triggered that. I see one other question, which is it our suggestion, is it my suggestion that we should have our staff receive immunization to various preventable infections? And my answer is yes. If you think about it from just a public health point of view, I think it's the right thing to do. But then from an administrative, programmatic point of view, can really help you prevent staff shortages when there are these sort of landmark cases that and you basically want to be able to preserve a working staff, and being able to prove immunity to things like measles when there's a rare case is really helpful to not have to have staff out for a long time and remain operational. So thank you.
Thank you, Jessie. And so that is all of our questions for today. I do want to remind participants of some resources that we have available. Our medical respite webpage has a number of resources. We have a toolkit, a medical respite toolkit, where you can find various policies and procedures. In that toolkit, you'll be able to find the Boston McGuinness House Infection Control Policies template that you can use for your own medical respite programs as you're trying to improve your infection control policies and procedures. We'll also include those infection control policies with the recording and copy of the webinar slides that will be on our website within the next few weeks. More information about the Respite Care Providers Network is available. And also, if you are requesting technical assistance or training, there is a link here for that. And please feel free to contact us if you have any technical assistance or training needs. And as always, there's a link to our archived webinars. At this point, I'll hand it back over to Julie, who can close us out. Julie?
Thank you, and thank you participants for joining the Infection Control Policies and Practices for Medical Respite Program webinar produced by the National Healthcare for the Homeless Council. Also, please visit the NHCHC website for a listing of upcoming council webinars and other educational products. And again, I do want to thank our presenters for such a wonderful presentation, and thank you, participants. This meeting will now be closed.